Welcome to this session on mastering proximal interphalangeal joint dislocations, a journey of evolution. PIP joint dislocations, initially dismissed as mere sprains, often spiral into fixed flexion deformities, revealing the profound impact of delayed intervention. Today we embark on a transformative journey through the annals of hand therapy, exploring the challenges posed by PIP joint dislocations and the evolution of management strategies. Let's understand the challenge. In the aftermath of a common hand injury, patients are commonly advised to buddy strap their finger, only to discover a fixed flexion deformity 3 months later. This deformity arises from factors such as immobility, poor positioning, and post-traumatic complications like soft tissue shortening, adherence, and scar formation. Seeking assistance from a hand therapist at this stage unveils collateral ligament shortening, scarring, and the emergence of boutonniere deformities. The challenge for the hand therapist is to choose the right orthotic intervention based on the evidence. Let's delve into the intricate realm of orthotic interventions designed to combat chronic fixed flexion deformities of the PIP joint. We'll explore the mechanical nuances of both static and dynamic orthoses. We'll scrutinize the findings of Young et al.'s 2018 review and dissect the principles guiding static, progressive, and serial static orthoses. Static orthoses, operating on a 3-point pressure, static or inelastic principle, stand in contrast to dynamic orthoses, which incorporate a mobilizing or elastic element to enhance force application of the joint. Young et al.'s 2018 systematic review, combining through 643 studies, underscored the need for additional research to solidify clinical reasoning in orthotic selection. Despite progress, a conclusive verdict on the superiority of one orthotic design over another remains elusive. Dynamic orthoses, heralded for their gentle, controlled, and persistent force application, but often contribute towards ongoing pain and heightened patient discomfort. So reflecting on the historical progression from early practices like the Caitner splint and predominantly passive range of motion exercises, to insights from Glasgow et al.'s 2012 randomized controlled trial, we uncover the challenges patients face in sustaining splint wear and its impact on achieving full active range of motion. Intriguingly, the systematic review reveals the potential of total end range time through serial casting. Not only does it exhibit a statistically significant improvement in patient-reported outcome measures, but it challenges the conventional belief in continuous splint wear, opening new perspectives on treatment duration. I propose a protocol of 5 days of immobilization in a circumferential cast, followed by active mobilization only using an MCPJ joint immobilization cast, as well as a finger extension orthosis at night to maintain gains in the PIP joint. But let's unlock the archives to gain a historical perspective of why this is a good idea. In the pivotal years of 1993 to 1995, the landscape of hand therapy literature witnessed transformative developments that echo through time. 1993 is a year of breakthroughs. Kirby et al.'s innovation was pioneering the application of circumferential POP casts to burn patients, unveiling a remarkable 50% increase in shoulder abduction and flexion post-plaster casting to reduce burn scar contractures. Now, contrary to expectations, casting not only softened scars, but also facilitated wound healing in open areas, even those with exposed tendons. Then we have Dr. Paul Brand's pertinent contribution. Dr. Brand emerged as a luminary, publishing Mechanical Factors in Joint Stiffness and Tissue Growth in the Journal of Hand Therapy. He was famed for his work with leprosy patients. He advocated for serial casting to combat finger deformities. And Dr. Brand's keen observations revealed the resilience of MCP joints to leprosy, emphasizing the value of active exercises and cautioning against passive stretching due to the absence of pain as a natural deterrent. Dr. Brand's profound philosophy on pain as an essential component of life, intricately detailed in Pain, the Gift Nobody Wants, became a cornerstone. Pain, according to Brand, was not an adversary but a vital survival mechanism. His gentle treatment approach aligned with the inevitability of gradualness. He emphasized the importance of pain without inflicting harm. In 1994, there was a focus on tissue growth with plaster casting. A significant stride was taken by Judith Bell-Krotowski and John Figueroa in unraveling the biomechanics of soft tissue growth with plaster casting. Their work illuminated the dynamic nature of tissue, showcasing how constant stress under plaster induced growth, creating a collagen network. Stress, they asserted, acted as a catalyst for tissue remodeling and mobilization. Dr. Salter's work in 1994, where he focused on continuous passive motion for articular cartilage healing, intersected with the plaster casting narrative. While emphasizing the optimum stretch time of 48 hours, it underscored the importance of joint surface gliding during movement and during joint mobilization. Bell-Krotowski echoed the sentiment and recommended joint movement between plaster cast changes every other day. Then in 1995, we started to have the development or the birth of the Sims technique and beyond. So the Sims technique was developed by Judy Kolditz, and it was inspired by Dr. Brand and Bell-Krotowski's principles. So this method redirects motion to the stiff joints, allowing active mobilization within the cast. It also involves immobilization of the MCP joints. So in 1995, Judy and Anne-Marie Schneider analyzed serial plaster casting and refined the technique for regaining PIP joint extension. Their modifications increased lever arm lengths, addressing mechanical inefficiencies. This particular design is something I have always used, and it is sad to see that even though this was published in 1995, therapists still use circumferential casts and omit to consider lever arm lengths. Following Judy's publication, I completed the course in 2003 and I applied this technique as described, but I began to notice that a step-down cast was needed in the form of an MCP joint immobilization cast that excluded the wrist component. I then designed the MCP joint immobilization cast, which initially immobilized the MCP joints in neutral and permitted full flexion of the PIP and DIP joints. Over time, I began to adapt this cast design further as a result of my work with flexor tendon injuries. The second design positioned the MCP joints in 30 degrees of flexion to reduce the power of the EDC, to enhance the recruitment of the extensor mechanism to extend the PIP joint. This enables motion of the PIP joint into flexion and extension. The second design immobilizes the MCP joints in either neutral or 30 degrees of flexion, depending on the presentation of the patient, and it immobilized the PIP joint to only allow DIP joint flexion. This permits FDP motion only. Initially, the FDP focus cast is worn 100% of the time to allow the patient to learn how to actively recruit FDP. And then the two casts are worn intermittently with a 70-30% rule, whereby 70% of the time the patient wears the FDP and FDS cast, and 30% of the time the patient wears the FDS cast. This will be discussed in more detail in another podcast, but it describes the history of the development of the MCP joint immobilization cast. I'd now like to present two case studies to show how using Judy Kolditz's design combined with the MCP joint cast and a static orthosis, we can actually get really good results for the patients. The first patient, she had a water polo mishap. In 2009, a water polo incident unleashed a cascade of challenges for this patient, whose right index finger bore the brunt of a radial dislocation. The aftermath revealed a 38-degree fixed flexion deformity and a distressing flexion deficit. Employing a plaster of Paris cast for 5 days initiated a 28-degree improvement in PIP joint extension, accompanied by reduction in finger circumference from 7.2 centimeters to 6.5 centimeters. However, digital flexion worsened, necessitating a shift to the MCP joint immobilization cast. Worn diligently during the day and at night, it addressed the intrinsic muscle tightness. The patient performed hook fist exercises, touching the index finger pad to the cast. Nighttime saw the application of a dorsal finger extension splint to maintain PIP joint extension. An astute 2-hour daily break from the cast allowed the PIP joint to rest in extension within a splint. The result, a remarkable 5-degree extension gain, a triumphant full fist, and a significantly improved hook fist. Noteworthy, meticulous measurement and photographic documentation of the hook fist proved essential, avoiding potential misinterpretation if only a full fist were recorded. It is often deceiving when you take photographic evidence and show just a full fist, but then when you ask the patient to make a hook fist, you can see the flexion deficit. The second patient is Annalise, who fractured her little finger. Annalise's tail unfolded post a conservative approach to a fractured little finger marked by subsequent joint stiffness. Surgeons intervened with a mobilization under anesthesia before steering her towards hand therapy. Embracing the MCP joint immobilization cast for 3 weeks, Annalise attended only 6 sessions and emerged with a full range of motion. Her finger seamlessly transitioned from a full fist to a hook fist, showcasing the cast's effectiveness in reclaiming digital flexion. So what recommendations do I have for surgeons and therapists? Firstly, surgeons, please discourage surgery and steroid injections or immobilization under anesthesia for PIP joint dislocations or fractures. Apply Judy Colditz and Anne-Marie Schneider's POP serial cast, which is designed to restore PIP joint extension. Utilize the MCP joint immobilization cast for digital flexion recovery. Avoid passive range of motion. Employ additional techniques and therapeutic modalities on the skin as needed. And evaluate if a full SIMS cast is necessary. Be mindful that directly opting for the MCP joint immobilization cast may delay results. Uphold the gradual approach in harmony with Brand's concept of inevitability and gradualness, emphasizing gentleness throughout the treatment or therapeutic process. Consider enrolling in my SIMS online training for comprehensive expertise, acknowledging that success lies in combining scientific understanding with technical proficiency. Part 2 of this podcast promises a deeper exploration of the latest scientific advancements and the integration of therapeutic skills in patient journeys. So join us as we further uncover the secrets to mastering PIP joint dislocation, because it truly is a journey of evolution and innovation. Thank you.